Good afternoon, everyone. My name is Maya Luria with TMC for Seniors. And today I am happy to share that we are going to be talking about help. I've been diagnosed with AFib. Now what? It's sort of perfect timing as we are also into our Brain Health Month and how this relates to stroke as well. I have Dr. Park with me here today. He is with Pima Heart and Vascular. He's an interventional cardiologist that specializes in structural heart procedures. Welcome, Dr. Park.
All right, thank you for having me. Sorry for the delay. So today I'll be talking about atrial fibrillation. Granted, I'm a interventional structural cardiologist, but we see a lot of atrial fibrillation. So I'll just go over kind of the generic aspects of atrial fibrillation pertaining to your cares. So briefly, three things. What is AFib? We'll go over that. What is the scope of the problem nationally, internationally? And how do we manage atrial fibrillation? So we'll go over those three aspects. So basically, atrial fibrillation, as the word connotes, is related to a process that occurs in the atria of the heart, which is the upper chamber of the heart. The heart has four chambers, two on the top, two on the bottom. The two upper chambers are called the atria or the atrium, and the bottom chamber of the heart is called the ventricle. So atria, ventricle, this is kind of looking at the heart from the front. If we look at the heart from the side, on the right side, this is the right upper chamber of the heart, the right atrium. This is the right ventricle. If we look at the heart from the left side of the heart, so this is an important structure we'll talk about. It's called the left atrial appendage. And if we look at the heart from the back side of the heart, these are kind of the pulmonary veins that drain blood coming from the lungs back into the heart, where it's then pumped into the body. So basically, what atrial fibrillation means is that the atria, or the upper chamber of the heart, are fibrillating. Normally, when the heart beats, there's an electrical circuit that arises from the right upper chamber of the heart, where the electrical circuits are passed on to kind of the main command center in the center of the heart, called the atrioventricular node, after which the electrical impulses go down the both bottom chambers of the heart, resulting in heart contractions. So the atria contracts, where the blood is flown down into the bottom chamber of the heart or the ventricle, and then the ventricle contracts and the blood is gone either to the lungs or to the whole body. So that's a normal heartbeat. But in atrial fibrillation, as you can see here, there's a chaotic electrical stimulation of the upper chambers, which result in random transmission of these electrical circuits down the heart. And at times, the heart can beat very fast in the 100s, 130s, 150s, even up to 200s, where a normal heartbeat, resting heartbeat, is between 60 to 100. So that's basically atrial fibrillation, kind of very simplified. So what symptoms can patients have with this irregular heart rhythm? So patients can develop symptoms of fatigue, shortness of breath. They may feel dizzy or lightheaded. They may feel that their heart is racing or palpitations. Some people may complain of chest discomfort, chest pain, chest tightness. But maybe a third of the patients may actually have no symptoms at all with the atrial fibrillation. So it's not just that people can develop these symptoms. Sometimes people may not actually feel that their heart is in an irregular heart rhythm. So we call that silent atrial fibrillation. So what are the potential causes of atrial fibrillation? Well, atrial fibrillation can be related to lifestyle things such as obesity, alcohol use, smoking, caffeine, whether it's coffee or energy drinks, and certainly activity level. but it is also associated with other medical conditions such as high blood pressure, heart failure, valve problems of the heart, prior history of heart attack, heart artery disease, sleep apnea, diabetes, thyroid problems. So all these medical conditions are associated with atrial fibrillation. And then there are non-modifiable causes such as one's age, whether they've had history of congenital heart defects or heart defects from birth, and family history, genetics, obviously that's not modifiable, and then one's sex. So if we look at modifiable and non-modifiable risk factors, as I mentioned, there are the non-reversible risk factors like family history, genetics, age, and kind of patient's body habitus. And then there are all these reversible risk factors that are important in atrial fibrillation. So when someone is diagnosed with atrial fibrillation, we also look to help modify these potential risk factors that may be contributing. So that's why atrial fibrillation is not just an electrical problem, it's a problem where we try to address all other cardiovascular comorbid conditions. So atrial fibrillation is also associated with risk of stroke. Patients with atrial fibrillation are at 5 times higher risk of stroke, 5 times higher risk of stroke compared to patients without atrial fibrillation. And that's because when the upper chamber of the heart or the atria are fibrillating, sometimes blood can slow in those upper chambers, and especially that appendage that I mentioned about, it's a small outpouching of that left atrium. And blood can pool there and potentially form blood clots, which can theoretically go anywhere in the body, and the most concerning thing would be a risk of stroke. And as you may be aware, stroke presents with various neurologic symptoms, but it can also present with dizziness, confusion, balance issue, weakness, numbness of the extremities, difficulty with vision, speech, understanding speech. And so these things are also a very important aspect when we manage patients with atrial fibrillation. Given that patients with atrial fibrillation are at increased risk of stroke, we always talk to these patients about blood thinners to reduce their risk of stroke. Now, blood thinners, on average, lower one's risk of stroke because it reduces the ability of the blood to clot in that upper chamber of the heart. But again, with any medication, there are always potential risks of the medication, and blood thinning medication in and of itself causes the blood to be thinned. So there are minor increased risk of bleeding, whether if you cut yourself or bruise, those would be a little larger bruises or a little more oozing with minor cuts, but can be associated with major bleeding risks, whether it occurs in the brain, in the lungs, or in the gut. So these are things your doctors will talk to you when they mention blood thinners to reduce one's risk of stroke with atrial fibrillation. Now, there are various types of atrial fibrillation. In general, there are basically 3 types: paroxysmal, persistent, and permanent. Paroxysmal atrial fibrillation, you may have heard, it's a type of atrial fibrillation that comes and goes. It stops on its own, and it can occur from seconds to minutes to days. That's why we call it paroxysmal. It occurs on and off. Now, when atrial fibrillation occurs for more than 7 days or a week, in general, we call it persistent atrial fibrillation, meaning it's persisted for several days, if not a week. And in general, in patients who have persistent atrial fibrillation, it won't really stop on its own. We would have to intervene to convert one back into a normal rhythm. And permanent atrial fibrillation is when a patient has atrial fibrillation chronically, or continuous atrial fibrillation. And in those cases, the heart cannot return to a normal rhythm. So 3 types of atrial fibrillation. Now, there are various theories as to what triggers atrial fibrillation. There can be various foci in the upper chambers of the heart that cause atrial fibrillation. There could be one potential focus on the left side of the heart near that pulmonary vein that I mentioned that may trigger abnormal electrical stimulus causing atrial fibrillation. There could be kind of a flutter wave throughout both chambers of the heart. There could be issues with the myocardium or the heart tissue that triggers atrial fibrillation. So there are various theories as to why one may have atrial fibrillation. And it's not just one abnormality. It could be various electrical abnormal issues or structurally abnormal issues of the atria that contribute. So as I mentioned, there are various triggers of electrical stimuli, but it can also be that the atria or the upper chamber of the heart are abnormally remodeled, whether it's due to inflammation, fibrosis, and depending on the type of electrical stimulation or the etiology of the atria being abnormal, one could move from paroxysmal atrial fibrillation to persistent atrial fibrillation to permanent. And about 25% of patients may proceed from paroxysmal atrial fibrillation to permanent atrial fibrillation in a year. Now that we've kind of gone over the basics of atrial fibrillation, I'll just briefly go over the scope of the current problem. So internationally, in 2010, they did a big review of how atrial fibrillation affects people around the globe. And in 2010, there were 33.5 million affected worldwide with atrial fibrillation. Now, if we look specifically in the US, that number was around 5 million in 2010. But by 2030, we anticipate that about 12 million people in the US will be afflicted with atrial fibrillation. And the prevalence of atrial fibrillation depends, as I said, again, on age. It's pretty rare in younger folks, but as we age, one's risk for atrial fibrillation definitely increases. And this is a different study that demonstrates again that above age 40, there is an exponential increase in one's risk of developing atrial fibrillation, just with age. So above 40, about 1 in 4 adults may develop atrial fibrillation in their lifetime. So atrial fibrillation is indeed a very common problem. Now that we've reviewed what atrial fibrillation is, we've also reviewed how it affects people here in the States and worldwide. We'll kind of go over basic cornerstones of atrial fibrillation management, which pertains to heart rate, the heart rhythm, and kind of stroke risks, and then lifestyle. So as I mentioned, in a normal heartbeat, the electrical stimulation of the heart occurs from the right upper chamber of the heart, where it's transmitted to the central command center, and then it kind of relays down to the ventricles or the pumping chambers of the heart in a one-to-one fashion. But in atrial fibrillation, there's a chaotic electrical stimulus that occurs in the upper chambers that can at times result in very fast heart rates and also very low heart rates. Now, the cornerstone in how we manage atrial fibrillation pertains to how we control the heart rate. Now, you may have heard of medications such as beta blockers like metoprolol, calcium channel blockers like diltiazem or verapamil, or even medications like digoxin. All these medications worked to control one's heart rate in atrial fibrillation. So as I mentioned, in patients with atrial fibrillation, their heart rates may range up into the hundreds, 150s, 180s. And so our goal in atrial fibrillation is to keep one's resting heart rate below 90, such that if they were to exert themselves or do activities, that their heart rate won't go excessively high. And so, again, the main management goal of rate control is to control one's heart rate in atrial fibrillation such that it's less than 90 beats per minute when the patient is at rest. Now, sometimes we can't achieve that with just the rate control medications, or patients may have excessive symptoms despite heart rate control, meaning patients may continue to have fatigue or shortness of breath or lightheadedness or palpitations or chest tightness, shortness of breath, despite heart rate medications. And in those cases, sometimes we consider to convert their atrial fibrillation abnormal rhythm into a normal rhythm. And there are various ways in which we can do that. One is cardioversion or electrical cardioversion, where we shock the heart into a normal rhythm. So that's cardioversion. There are also medications that we prescribe in patients with atrial fibrillation who have symptoms called rhythm medications or antiarrhythmic medications. But these medications can certainly have potential side effects, and there are various classes of these medications. And in general, we like using these medications in consultation with our electrical doctors or electrophysiologists. The other things we consider in patients with atrial fibrillation are procedures, ablations. So basically, ablation is a procedure where the electrophysiologist or the electrical doctor of the heart puts catheters into the heart. If you remember the slide where there were various electrical stimulus of the upper chamber, they put catheters in those upper chambers of the heart and electrically map these abnormal circuits or abnormal electrical rotors, as you may say. And once they identify those abnormal focus, they try to zap or electrically ablate those areas such that those electrical stimuli don't occur. And so that's an ablation procedure. As I mentioned, patients with atrial fibrillation are at increased risk of stroke 5 times on average, more so than people who do not have atrial fibrillation. So an important aspect in how we manage atrial fibrillation is to reduce one's risk of stroke. And what's one's risk of stroke? Well, one's risk of stroke depends on various things, and that pertains to if they have a history of heart failure in the past, what their age is. The older you are, the increased risk you are at risk of stroke. If you have a history of high blood pressure, diabetes, if you had prior stroke, whether it's TIAs, transient ischemic attacks, or true strokes. If they have history of vascular disease, whether it's heart artery disease or plaque in the leg arteries, or plaque in the carotid arteries. And then sex category, so females tend to be at slightly higher risk of stroke. So depending on these kind of risk factors, we come up with a stroke calculation and assess what one's potential risk of stroke on an annual basis is. And the more risk factors you have, obviously the increased risk of stroke you are at. And so above the score of at least 1 or 2, we do tend to recommend consideration of blood thinning medication to reduce that risk of stroke. So again, this is, as I mentioned, we do always have to balance the benefits of blood thinning medication with the risks of blood thinning medications. And in general, most people are able to tolerate blood thinning medication to reduce their risk of stroke, unless they've had maybe prior history of gastrointestinal bleeding in the past, or if they've had recent bleeding in the brain. But these are things that your doctors will discuss with you before initiating blood thinning medication. So there are two different types of blood thinners that you may have heard of. One is warfarin or Coumadin, and it's a medication that affects the vitamin K kind of pathway of blood thinners. But there is a downside where you do have to check your blood initially, at least very frequently, to make sure that your blood thinning level is adequate, because food can affect these medications, and your blood thinning medication may fluctuate depending on your lifestyle and your diet. Now, nowadays, over the past decade, we've been using what we call direct oral anticoagulants. You may have heard on TV things like Xarelto, Eliquis, Pradaxa. These are medications, blood thinning medications that act very quickly, such that once you take it, you don't have to check any blood thinning levels. Your blood level is thinned, and it's quite effective. So these two are potential medications that could be tried. Just interesting note is warfarin was discovered incidentally back in the 1920s when kind of cattle stock were dying of kind of bleeding, internal bleeding, and they were dying because they were kind of eating moldy hay at that time. And at that time, there was a lot of financial issues with the World War. And initially, over a decade, the government said, avoid moldy hay for your livestock. But one winter, this young farmer had enough of it because all his cattle were dying of bleeding. And so he took one of his cattle and their blood sample to a researcher at the University of Wisconsin, and they ran some further testing on that thinned blood, and ultimately kind of led to development of warfarin or Coumadin. It was initially used for rat poison, but then President Eisenhower used it in the 1950s after his heart attack, and then subsequently became widely used in the field of cardiology. So that's just the backstory. Now, in some patients who are at increased risk of bleeding, or if they've had significant bleeding where they needed blood transfusions, there are procedures nowadays where we can occlude that left atrial appendage where blood can potentially pool and form blood clots. And these are called left atrial appendage occlusion procedures. And there are two commercial devices available. One is the Watchman, one is the Amulet, depending on one's shape. There's various shapes of appendages, whether they're windsock in appearance, cacti in appearance. Some look like chicken wing or cauliflower. So one's appendage, not everyone has the same appendage, and everyone has different shapes, different sizes. And so in patients who are at increased risk of bleeding, whether they've had significant GI bleeding or brain bleeds, or if they're at increased risk of falls, because obviously when you fall, you are at definitely increased risk of bleeding. In those cases, sometimes we can talk to these patients about these procedures where we occlude these appendages with the goal ultimately of coming off these blood thinners and only remain on aspirin for life. So this is a potential procedure that could be performed in patients with atrial fibrillation. Now, as I mentioned, lifestyle is a very important aspect in how we manage atrial fibrillation. Increased weight obviously is associated with high blood pressure, diabetes, sleep apnea, inflammation, and when one's more obese, there can also be fat accumulation around the heart, which is an increased stimulus for atrial fibrillation. So there have been various studies that demonstrated that in patients who actually have sustained weight loss, their risk of recurrent atrial fibrillation is significantly lower than patients who have not had those weight loss. So weight management and its associated comorbidities is definitely a target that we try to address in patients who have atrial fibrillation. In addition to weight, alcohol has been shown to be associated with increased risk of atrial fibrillation. There's been studies that demonstrate that in patients who are abstinent of alcohol for at least 6 months, compared to those who continue to drink alcohol, the risk of atrial fibrillation there on the red line is definitely lower than patients who continue to drink alcohol. So alcohol is associated with definite increased risk of atrial fibrillation. In addition to weight and alcohol, as I mentioned, the comorbid conditions are definitely associated with atrial fibrillation, like high blood pressure, diabetes with its associated inflammation. Sleep apnea has definitely also been a trigger for atrial fibrillation, and sleep apnea in and of itself is also a risk factor for stroke and heart attack. And so targeting these comorbid condition in patients is very important when we try to manage atrial fibrillation. So in conclusion, I would say atrial fibrillation is very common. About 25% of adults over the age of 40 may develop atrial fibrillation in their lifetime. Patients with atrial fibrillation are, as I said, at increased risk of stroke, up to 5 times increased risk compared to those without. And in patients with atrial fibrillation, we have to discuss their risk of stroke and talk to these patients about blood thinning medications. And as I mentioned, there are various strategies in how we manage atrial fibrillations pertaining to medications, cardioversions, ablations, other procedures.
So thank you so much, Dr. Park. I have a couple of questions I wanted to ask you from our online audience today. Are there any foods that we should avoid if we're having any kind of atrial fibrillation?
Can you repeat that again?
Are there any foods somebody should avoid if they're having AFib?
So, not necessarily. Things that, as I mentioned, have been associated with atrial fibrillation include alcohol, caffeinated beverages, whether it's caffeine or energy drinks. Those are kind of the main things I would think about. The other things are illicit drugs that can be potentially associated with atrial fibrillation.
Okay. And I had a question come in.
Illicit drugs? Yeah.
What happens if you have an AFib event 6 months after an ablation? What would somebody do at that point?
Yeah, so that's a very good question. So in general, atrial fibrillation ablation is in general pretty successful procedures. Success rate is, depending on the mechanism, as high as 85, 90%, but some patients may have recurrences. And in those patients, obviously we would assess their duration of recurrence, whether it's very brief, meaning seconds to minutes, or hours or days. And in those patients, sometimes we can offer second ablations, which go very well, and they may remain free of atrial fibrillation for quite a long time.
Okay. And if you did need to have an ablation, what does that procedure look like as far as how long are you in the hospital? How long is that procedure? What does that look like?
So the ablation procedure is usually an outpatient procedure. In general, people may be monitored overnight in the hospital, but go home the next day in general. In general, we use kind of the groin veins to access the heart, the right side of the heart as well as the left side of the heart. And depending on where the electrical stimuli are originating from, the procedure could be quick, hour, but it could also be several hours.
Okay. And what I know we talked a little bit about lifestyle in your presentation. Are there activities that somebody should avoid if they have AFib, or are there activities that they really can, are safe for them to do?
So I think it kind of depends on also what symptoms they're having.
What's the question? I can't understand.
So activities, are there certain activities that patients with AFib cannot do or should do? So I think it depends on one's symptoms from atrial fibrillation, as well as kind of what their heart rate is. Because obviously as we exert ourselves with increased demands of the body, our heart rate does increase. And in patients who are in atrial fibrillation, if our ideal goal is to keep their resting heart rate below 90, certainly with exercise, that heart rate will increase. If a person has inadequate resting heart rate control with well-controlled symptoms, I don't think there is necessarily any exercise that is prohibited per se. I think it kind of depends on how well their atrial fibrillation is managed to kind of discuss what activities they should and should not do.
Okay. Now, I know you talked a little bit about sleep apnea being, an issue. Do you oftentimes with AFib, you feel tired and short of breath? If you sort of resolved the heartbeat not beating as fast, but you're still having those symptoms, what steps would somebody take?
So if they still have symptoms with atrial fibrillation,
There's just feeling tired and short of breath, still after trying to resolve they're not having a fast heartbeat anymore.
Okay, so if patients are still having symptoms with just their heart rate control, then as I mentioned, we can try to see if we can get them out of atrial fibrillation, whether it's through cardioversion, through other rhythm medications that try to keep people in normal rhythm, or these ablation procedures. So it's not that heart rate control is the only goal of patients with atrial fibrillation. It's a combination of both. And up until a few years ago, our initial focus was heart rate control, but nowadays we also try and see if in patients who've had a new diagnosis of atrial fibrillation for the first time, we can try and see if we can get them out of atrial fibrillation to see if these symptoms may potentially go away.
Okay. If somebody is interested in an appointment, I do want to put up the phone number here for Pima Heart and Vascular. It is 520-838-3540, or you can obviously also go to pimaheartandvascular.com. What office do you work out of, Dr. Park?
I work out of our East Side office, which is Fort Lowell, East Campbell, and then St. Joe's, near St. Joe's.
Okay, great. I want to thank you so much for being here today. I'm going to wrap up with our online audience, and I will turn it over to you to answer any questions in person. So thank you so much for being here today.
Thank you.
Thanks again for being here. We will be back in tomorrow. We have another class tomorrow, Wednesday, March 6th at 10 a.m. And that is A Spectrum of Aging, the Wisdom of Aging Well, as part of our Brain Health Month. If you are interested in this class, please give us a call at 520-324-1960. Have a great day.